Welcome to AETCM, the Emergency Medicine channel. 18-year-old female patient came to ER with complaint of left-sided facial deviation. Started within 1 hour of onset after waking up from sleep. On initial 10-second assessment, patient was conscious and oriented. Airway was patent. There is no pouring of secretions. Breathing was higher and bilaterally equal. Respiratory rate 18 breaths per minute. Saturation 98 on room air. Circulation blood BP was 110/80 mm mercury. Pulse rate 88 per minute. Disability GCS E4 V5 M6. Pupils stimulated bilaterally reacting to light. Exposure blood temperature was normal. Coming to history, sir.
Okay, so we have an 18-year-old girl who has come with a sudden onset of right-sided facial weakness. Right side or left side?
Left side of facial weakness. Right side of facial weakness.
Okay, she noticed some facial asymmetry, so that's why she came to the emergency room 1 hour back.
1 hour back.
Okay, now what are the other history? Can you just add on? What is the sample history?
Sample history: 18-year-old female came to ER with a complaint of left side facial deviation within 1 hour of onset from waking up from sleep. She noticed it while brushing the teeth.
Okay.
There is no history of any weakness of any limbs. There is no history of any fever. No history of any gastroenteritis, vomiting, travel. These are the negative histories.
Okay. So sudden onset of facial weakness. Maybe 1 hour she is telling. She is noticed 1 hour back only. Maybe it would have developed during the sleep. We don't know. Because when she started brushing her teeth, she found out that there is some facial weakness and she has come to the ER. Now, how will you, an 18-year-old girl, how will you go ahead with the assessment now?
Assessment wise, after history taking, we will go to examination part.
So, cranial nerve examination. So, cranial examination, you have to do a full cranial nerve examination. 7th cranial nerve, you have to do completely. But what are the key things that you can do a quick cranial nerve examination? If I am telling you to do a quick cranial nerve examination in the ED for a patient that has come to the emergency, what are the things that you will do for a quick thing? I am not asking you a detailed cranial nerve examination. I am not looking into that. At least 7th cranial nerve you tell me. How will you assess a 7th cranial nerve? And 8th cranial nerve comes together. 7th and cranial nerve and 8th will usually assess together. So what are the simple things, even olfactory, smell? You can just ask her how she is feeling, any smell difference, she is able to see that. You don't have coffee powder and all, that's fine. You don't keep that in the ED, whether she is able to appreciate that. Visual acuity, you can simply ask her to read what is there. You can give her your notes and see whether she is able to read that one or not. And ask the color difference. You will have triage coding in the ER. So ask her whether she is able to primary colors. You should be asking whether she is able to differentiate that colors. So that completes our ophthalmic cranial nerve. Then the next thing, just movements, any diplopia, any ptosis, you can ask for this thing and you can just quickly examine those things. That doesn't take any time. Then muscles of mastication. Then the most important muscles of mastication, you can ask her to move and chew and see. Then comes to the cranial nerve, 7th cranial nerve. So how will you assess the 7th cranial nerve?
7th cranial nerve, you can ask to wrinkle, whistle.
So before that, you should know what are the things that you need to examine in the 7th cranial nerve. You need to do the motor. We need to assess the sensory, 2 things, and special sensations. So these are the 3 things when it comes to for the facial nerve. So one is facial nerve to the facial muscles, muscles of facial expression. The next thing, sensory, pinna and the external auditory meatus. Then anterior 2/3 of the tongue. So these are the 3 areas that you should be necking. And parasympathetic we will be unable to assess. That is the parasympathetic secretory fibers to your submandibular and the parotid gland, which we will not be able to assess. So what all things we can do is you can just ask her to smile, whistle and all those things, and you can look for any facial weakness is there or not. So the key thing when you are doing assessment, whether you need to differentiate whether it is an UMN versus LMN facial palsy. So that is the most important thing in an ED, what we need to understand, whether it is a UMN or an LMN facial palsy. So motor, sensory, special sensation. So these 3 things that what you need to have. There are 3 nuclei. These are the 3 nuclei for the 7th cranial nerve. Okay, so how will you differentiate between whether it is a UMN facial palsy or an LMN facial palsy? So simple in the ED, how will you able to differentiate it?
In ED, LMN facial palsy, one half of the face will fully affect an LMN facial palsy, and UMN facial palsy only the lower half of the opposite side of the affected.
So ipsilateral and contralateral. So whenever it is LMN, usually it is ipsilateral and completely the whole side of the face will be affected, including your furrowing and up frontal muscles, everything will be affected. When comes the UMN facial palsy, usually it is affecting the opposite side, and usually the lower half of the face only will be affected. So how will you do that assessment? How will you differentiate clinically?
Clinically, we ask the patient to wrinkle the forehead.
Okay.
And ask to close the eyes.
And try to open against the resistance. And try to open the eye against the resistance. If she is having weakness, we will be easily able to open the eye. So that is the key differences that we need to make. So I'll just summarize what you have said. We have an 18-year-old female who have come to the ED with probably overnight. We don't know, but at the time of brushing her teeth, she have found out that she has got some facial deviation to the left side, and she has come to the emergency room, and she don't have any limb weakness, bulbar palsy or anything. We don't have any other symptoms. Only this thing is what. And on your clinical examination, what did you find?
LMN facial palsy.
Which side?
Right side.
Right-sided LMN facial palsy that you have found out. Now we have a patient with LMN, right-sided LMN facial palsy. So what are the differential diagnoses that you need to consider?
LMN facial palsy, commonly Bell's palsy.
Okay, so we have to divide whenever you have a facial nerve palsy, as I told, UMN and LMN. So let's see what are the reasons for UMN facial palsy. It is pretty simple, precentral gyrus. So that is the nuclei for the UMN. So we have a middle cerebral artery infarction, your UMN facial nerve will be affected. So that is the first reason when you get an UMN type of facial palsy. Then UMN type of facial palsy, from the precentral, it comes to the pons. So that is a corticobulbar tract. So that is the second order neuron for the cranial nerve. If that is getting affected, again you will have an UMN type of facial palsy. So these are the two reasons you can get an UMN type of facial palsy. Now let's come to this patient. Where all you will get an LMN type of facial palsy? Intracranial and extracranial. We need to divide. Intracranial also you can develop, we have a brainstem stroke. You can develop an LMN type of facial palsy. But extracranial is what we see commonly. What we are suspecting in this girl is an extracranial facial nerve palsy. So what are the reasons? First, as you said, commonly is Bell's palsy. Second one? Second one?
In the pontomedullary junction.
No, extracranial. I am telling you extracranial. Intracranial is over. Intracranial LMN is over. Extracranial LMN.
Ramsay-Hunt syndrome.
Ramsay-Hunt syndrome. So then? Trauma. Okay, then. So where exactly in trauma it can get affected? Which all bone fractures? Temporal bone fracture. Where does the cranial nerve 7 exit? Stylomastoid foramen. So anything nearing that area, you should know the pathway. So what is the pathway?
After the brainstem and into the middle cranial fossa.
So what are the segments you know? Then it is very easy. Segments. First one.
Segment cranium.
Then meatal. Then labyrinthine. Then mastoid. And finally it comes out to the stylomastoid foramen. So anywhere there is a lesion, it can affect your cranial nerve. So Ramsay-Hunt syndrome you said, then trauma you said, Bell's palsy you said. You are telling for reasons for LMN facial palsy. What are the other rare causes? Lyme's disease. That are the rare causes. HIV infection. A Guillain-Barré syndrome, very common. A Guillain-Barré syndrome with cranial nerve involvement. Then sarcoidosis. So these are some of the rare instances, but most commonly is the Bell's palsy. So when you have an LMN facial palsy, our idea whether the brainstem or whether it is not a brainstem. So if it is a brainstem, it will look like a stroke. They might have other cranial nerve involvement also. Like they have difficulty in swallowing. What are the things that is arising from the pons, midbrain, you can think of brainstem area. All those things will get affected. But when that is not affected and you have a patient with LMN type of facial palsy, we have to think the probable differential diagnosis. Now, from the history, from the clinical examination, we think it is a probably, we don't see any lesions. So we are probably thinking of ruling out a Ramsay-Hunt syndrome. We are thinking in terms of a probable Bell's palsy. Let's come, what is Bell's palsy exactly? Where is the problem in the Bell's palsy?
Bell's palsy is the element facial nerve palsy by the compression of the facial nerve in the compartment of the facial nerve.
So that is a long segment. Now, where exactly usually the edema will happen, or what is the pathophysiology behind Bell's palsy? Usually, when you look at the pathophysiology, you can't say this is the reason, which is very difficult to find out. One thing that they have attributed is herpes infections. One thing that they have found out. The next thing is that they don't find any reason. Overnight, there might be some ischemia to the facial nerve because of the edema from the canal, wherever it is coming. When the labyrinthine area, the lumen is very narrow. Even a small amount of edema develops in that area, that will affect the whole cranial nerve. So that is the reason why they have attributing. They have not found out any reason. So that is why we don't have any specific treatment as such for Bell's palsy. We can think that probably it is a herpes infection and we are giving them antivirals. So maybe for 1 week time, you can give acyclovir or valcyclovir, whichever it is, you have to give for 1 week. So what is the dose of valcyclovir?
1 gram TAD.
1 gram TAD for 7 days, or valcyclovir, or sorry, acyclovir 800 mg 5 times a day into 1 week. So that is the reason why we are giving. And next thing, to decrease the edema, we are giving steroids. The next common question, doubt in the people's mind when they are treating is steroid, how long you need to give? Ideally, steroid is only required for the first 1 week. After that, it is not required. So initially 1 week, whatever be the edema, that will be taken care of. 1 milligram per kg of your prednisolone, viscon, whatever be it is. And when you are continuing steroid for more than 2 weeks only, you need tapering dose. So you don't need a tapering dose here. So you can give a like 40 mg OD for next 7 days and you can stop it. And you can ask them to review later. So that is the 2 drugs that you need to remember. Whether you need an MRI or not. That's my next question.
Ideally, if there is no other weakness, we don't.
Ideally, it is not needed. Ideally, it is not needed. It's a sudden onset. If you think that it is definitely a Bell's palsy. So what are the history that probably suggests Bell's palsy? What is the most common history that you can ask for?
Any previous history of any viral fever like
Okay.
like any lesions like
What commonly, I don't see that there is any reason behind it. I don't know. Usually these people will come early morning. So one history, whatever patient I have seen, couple of them have significant exposure to cold temperature. They were traveling in a two-wheeler or they were traveling in a car with glass down. So that a lot of air will come and hit there, and as a result, that was only few patients that whatever I had seen, they had this history. So whether, if you look into the literature, there is no evidence as such, but whatever patient I had seen, like 30 to 40% had this history. One fellow was staying inside a colder room and the fan was on during that time, and the next day morning he developed a Bell's palsy. And similarly, the open window travel in a car, AC car travel, and all those things has been something that has been we have found out. And this girl didn't had any history. Basically, she is from Munnar, but she's staying in Cochin. But Munnar, again, it's a cold temperature. Again, that sort of history might be that I asked her, but there was no history. So it is basically, you cannot find any reason why she has developed this. But maybe very rarely, when you are thinking of other cranial nerve involvement, definitely an MRI is required, or whether it is a gradual progression. Whether it's a gradual progression, it came and when it progressively it is worsening. So we are thinking in terms of whether it's a tumor that is growing there. So the gradually, because of the edema, the patient has come in, or whether you have any other signs of raised ICP, whether the patient has any other weakness, then definitely an MRI is required. Routinely MRI is not treated. So that's why I said when you are thinking in terms of a brainstem stroke, yes, you need an MRI, but otherwise, routinely for a Bell's palsy, we don't need an MRI. Now, what is the treatment option? We have discussed 2 medications. What are the most important treatment? 1, 2, 3, 4. You wanted to send off this patient from the ED. What are the advice that you will give to the patient?
As soon as possible, patient came, we start with steroids and antivirals.
Okay.
Then physiotherapy is mainly important, and physiotherapy like exercise and electric stimulation of the muscles also required.
So the most important thing, which area is maximally affected, we need to say. We know that it is divided like this. The cranial nerve, the last 5 branches. So we need to evaluate which branch is maximally affected. So depending upon that, each cranial nerve we can stimulate electrically. And as a result, this girl didn't have much of eyelid involvement. She had more of facial muscle involvement. So that is what is required. So the physiotherapist or the PMR specialist should be targeting that nerves and they should be giving stimulation exercises. That is one. How long you need to continue? So ideally, when you look at 3 to 4 weeks of physiotherapy or this electric nerve stimulation is very good. When you give that, the patient recovery chances and everything will be more. And what is the next advice that you will give her? If you don't have a physiotherapy facility, you don't have a consultation facility, so what all advice you can give her?
Chewing exercise.
Chewing exercise. You can ask her to put a bubble gum and chew on that side. That's a simple exercise that you can tell. Then what else next? 2, 3, 4, 5 exercises you can tell. Ask her to light a candle and blow off the candle from a distance, so that you are blowing it out. So that will again help us to improve the facial nerve. Then ask her to blow a balloon. That's a simple thing. You can ask her to put a balloon and ask her to blow it. So these are the simple exercises that you can teach the patient when you are planning to dispose. Mostly, what is the most important? Exposure keratitis. You have to prevent exposure keratitis, because the one of the eyelid will not be getting closed while sleep. So it will be open and lot of dry air will be coming and hitting the eye. As a result, the patient will develop exposure keratitis. So what do you need to do? You need to pad the eye while she is sleeping, and you need to give some lubricating agents also. The problem with lubricating agents, you have two types of lubricating agents. You will get a liquid type of a lubricating agent which will act only for 1 to 2 hours. So when you are asking her to sleep, you cannot wake her up every 1 hour and you cannot lubricate. So what you can give a gel sort of a prescription. So lacquer gel, that is one thing that is available, that will act for 6 to 8 hours. So during night hours, you can ask her to apply this gel and pad the eyes and she can sleep. And the daytime, she can put our normal refresh eye drops or artificial tears, whatever is available, you can use that. So these are the key instructions that you need to go, and you need to tell her, because an 18-year-old girl, she will be very much worried what is going to happen to this. So it is not going to improve within the next 2 to 3 days. But as time improves, she will definitely, within maybe 3 to 4 weeks, but definitely there might be some residual weakness. But when you are doing a good physiotherapy and all, the residual weakness also will go off. Okay, so what are the additional things, anything we have done for her?
Then classifications are basically acute Bell's palsy, evaluate the eye closure and grade the degree of facial weakness according to House-Brightman classification. And evaluate the eye closure. If it is adequate, no need for eye protection needed. If inadequate, implement the eye protection measures. Grade the degree of facial weakness. If mild to moderate, early treatment with corticoid like prednisolone, 40 to 60 milligram OD per 1 week. Then severe to complete, early treatment with glucocorticoid addition with antivirus like acyclovir or valsiclovir added. Then follow-up of evaluation. If complete recovery, then if incomplete recovery, consider botulinum toxin injection for facial spasm. And slow progression of weakness, we are ready for neuroimaging to rule out any malignancy.
So that's it. It's a simple disorder, but you need to counsel her. An 18-year-old girl, she will be totally devastated by seeing her in the mirror. But you have to tell her, like 4 to 6 weeks of physiotherapy, she should be absolutely normal. That should be her advice that you need to give. So whenever you get a facial nerve palsy, in the ED, our main thing, differentiate whether it is a UMN versus LMN facial weakness. From UMN, I have told the reason why all you can have UMN. You are thinking in terms mostly like a stroke. And LMN also, it can be intracranial and extracranial. Intracranial, again, it can be a brainstem stroke. And when it is extracranial, it is probably Bell's palsy, Ramsay-Hunt syndrome, your GB syndromes, variants of Miller-Fisher variant. Then you have the sarcoidosis. These are all rare manifestations, but just keep an eye. And trauma, again, in an emergency room, you need to consider that also as the one of the differential diagnosis. When you suspect an LMN with a brainstem involvement, that definitely needs an imaging. But routinely, you don't need an MRI for Bell's palsy. Key things is to start steroid as early as possible, antiviral treatment and early physiotherapy. That should not be just continuing for 1 or 2 days. It should be continuing for 4 to 6 weeks. Then only that recovery will happen. And remember regarding exposure keratitis also. Okay, fine. Thank you.